Hello, thank you for listening to this training presentation about dysphagia, which is in addition to the dysphagia e-learning that is available. My name's Rena Birchall and I'm the speech and language therapist here at Care for Veterans. These are the topics to be covered in this video. What is dysphagia? The role of the speech and language therapist, the IDSI framework, use of thickener in drinks, providing mealtime assistance, and we will also discuss a case study. So firstly, a refresher about what is dysphagia. So dysphagia describes eating and drinking and swallowing difficulties in infants, children and adults. It's caused by a disruption to one of the stages of the normal swallowing process. There are several different conditions and factors which can cause dysphagia, and these may be neurological, mechanical, or a combination of different features. Now to go on to a bit more detail about the causes of dysphagia. Dysphagia in adults can occur as a result of any of the following medical problems, and this list is not exhaustive. There are many neurological disorders which affect many residents here at Care for Veterans, including stroke, dementia, Parkinson's disease, multiple sclerosis and head injury, cardiopulmonary and respiratory conditions such as COPD, general medical disorders such as UTIs and sarcopenia, which is generalized physiological weakness as one gets older, disorders caused by trauma such as smoke inhalation, swallow disorders as a result of surgery such as thyroid surgery or a tracheostomy, and ventilator dependent individuals, so people who have been on ITU and have been intubated, they may have a trauma from the intubation affecting the muscles and cartilages involved with swallowing. And there are also psychogenic causes and various head and neck cancers that can cause dysphagia. You will already be familiar with the signs and symptoms of dysphagia, but here is a refresher. Coughing or choking at mealtimes are some of the clearest signs, as well as throat clearing. There may be pocketing of food in the mouth and residue, shortness of breath, fatigue. The person may experience frequent chest infections and aspiration. There may be a sensation of food sticking in the throat. They may take a long time to finish or chew meals. And there may be bringing up of food or expectoration of food. These are some of the consequences of dysphagia. There may be chest infections, pneumonia, e.g. aspiration related. Weight loss, malnutrition and dehydration can happen over a period of time if the dysphagia has taken a while to be diagnosed. And what I do in my role as a speech and language therapist, I'm happy to receive referrals from staff in person or via email, and I will always make a note of any referrals received on PCS. I do a bedside assessment of the swallow and then make recommendations, which might include thickening drinks, food modification, and swallow therapy techniques or maneuvers which may be helpful. I may also refer someone for a videophroscopy. Quite a few residents have had videophroscopies during the time that I've been here at Care for Veterans, and they usually take place at Worthing Hospital or St Richard's. Now to talk a bit about IDSI levels, which is a standardized framework describing food and fluid textures someone can be recommended. Firstly, just a reminder about why IDSI is important. As you can see from this case, this gentleman was recommended a puree diet but died after he was left alone with conkers that he swallowed. The staff in this case did not pay enough attention to the care plan, which clearly stated that he should not be allowed access to items which might be mistaken for food. So this highlights the importance of following care plans about dysphagia and oral intake. So the IDSI framework of course includes details about thickened fluids, and I'll go on to talk about thickened fluids in more detail in my other video. However, you should be aware about new guidance about thickener, which is that the evidence indicates that thickener does not always prevent a dysphagia-related aspiration pneumonia or improve quality of life. It should not be used as a blanket approach. Any decisions about using thickener should be person-centered and consider the patient's wishes. Ongoing review and monitoring is required by the speech and language therapist and medical staff. And now to speak a bit about IDSI food levels, which you will all be familiar with. Firstly, level 4 puree diet, which is completely smooth with no bits. It's the easiest diet to manage, and it should hold its shape nicely on a spoon. Level 5 minced and moist diet has a bit more texture than level 4 puree. The food particles should still be very small and should be able to fit between the prongs of a fork. It should still be very easy to chew and to swallow. Level 6 soft and bite size should be small cube-like pieces of food, about 1.5 centimeters in size. More chewing is required, but it should be soft in texture throughout to make it manageable. Level 7 easy to chew are the naturally softer foods from the normal menu. The main way to test this is, can a side of a fork or spoon cut through easily? Level 7 regular diet is unrestricted in texture and other foods not covered by previous levels. Some residents are recommended transitional foods. These are foods which change from one texture to another, for example, when saliva is added. Typical example of these types of foods are Wotsits, wafers, and thin chocolate. Here are some examples of food that may cause a higher choking risk. Hard foods such as boiled sweets and nuts, crumbly foods such as biscuits, foods with seeds, pips or skins, tough and chewy foods like steak, bacon, hard vegetables, etc. Foods with skin, bone and gristle, sticky foods such as marshmallows, juicy foods like melon where the juice separates, round long-shaped foods like sausages and grapes, dry foods such as crackers, stringy foods such as pineapple, floppy foods like salad, foods that have a mixed texture like bits of cereal in milk, crispy crunchy foods like crisps or pastry. There are some residents who are eating and drinking at risk, which is continuing to eat and drink despite a risk of aspiration or choking. This risk is present despite input from a speech and language therapist and/or all other interventions have been explored. It is always a person-centered decision and usually in place for certain reasons, such as the advanced stages of an illness, the swallow is unlikely to improve, chewed feeding is not appropriate, etc. The focus is on comfort and the easiest drink and food options to swallow, and also personal preferences. Some general advice at meal times when you are assisting someone. Ensure they are as upright as possible. Introduce the meal for the resident, explain what you are doing and check they are okay with it. Check the pace at which you give food or drink with the resident. For people on thickener, make fresh drinks throughout the day. Make sure what you are providing for residents matches their IDSI recommendation. If not, please be prepared to challenge or question this. Feedback from residents taking part in a mealtime experience project. Generally, it was very positive about staff who provide support with feeding. Most residents responded always when asked if they are helped at the correct pace and offered the right amount of food and drink. Most residents prefer to be assisted from a side-on or front position, and a balance is required between social interaction and swallow safety. Overall, mealtime experiences should be personalised to meet individual needs and preferences. Here is a case study to consider. A resident says she no longer wants to follow speech and language therapy advice and wishes to eat and drink what she wants. A mental capacity assessment was completed, and she is deemed to have capacity for this type of decision. She is not fully able to feed independently, therefore some members of staff are uncomfortable of this. The speech and language therapist is not on duty when this occurs. How would you proceed? A few moments to think about this case. So here are some of the main points to consider. So first of all, refer to the mental capacity assessment that was completed to ensure that you document everything in detail about the decision that has been made. If there is correct documentation in place, a staff member should not be liable if there are any possible negative consequences as a result of the resident's choice. And it is a human right to make a choice which cannot be denied with this decision. And please discuss with senior staff if unsure. So that's the end of this video presentation. Please feel free to contact me in person or email if you have any questions, or to arrange a meeting if you want to go over anything in more detail. Thank you for listening.